So I think all of us, whoever is sitting here, every day and almost every week we will be facing through these obstetric emergencies. So in an obstetric emergency, it's very important that we work as a team. And it's very important that we work as a multidisciplinary approach. And it's very important that we remain calm. And we shouldn't be stressed up at that point of time. And it's also important that we have to scribe all the events in an order. You should allocate somebody to scribe the events. The reason is, whatever you are doing, it has to be documented. If you have not documented, that means that it is not being done. And there should be effective communication between the team members. And once we have completed with the emergency, we have to debrief the session, preferably in the audiovisual setting with the patient and the family, and also in between the team members. Sometimes when we are dealing with the emergency, it's not only the patient and the family going through the trauma, it is the team also goes through a lot of trauma. And obviously we need to support each other, and we have to discuss what we have done best in that emergency and what should have been done better for the future. And it comes with regular participation in obstetric drills. So first of all, I'm going to take you through the shoulder dystocia. And shoulder dystocia is any cephalic delivery where the maneuvers other than gentle traction are required to deliver the baby after the head has been delivered. It's mainly the bony impaction of the anterior shoulder of the baby against the maternal pelvis. And it occurs in 1% of the deliveries. And this is the third most litigated obstetric complication. So why are we so worried about this condition? Because it leads to maternal and perinatal morbidity and mortality. For the mother, it can cause the PPH, obstetric sphincter injury. For the baby, it can cause brachial plexus injuries and fractures. And also, the more dreadful is the HIE, hypoxic ischemic encephalopathy, and the death. And obviously, if the C5, C6 nerve roots are damaged, it leads to the Erb's palsy, and if C8 and T1 are damaged, it leads to the Klumpke's paralysis. And can we predict this condition? Obviously, in some instances, yes, if the baby is macrosomic, that is more than 4 to 4.5 kilos, and if the mother is diabetic, or if the patient had history of previous shoulder dystocia, or if there is history of prolonged labor, and instrumental delivery also predisposes for the shoulder dystocia, more with the venous delivery. So if you look at this chart, as the baby's weight increases in the diabetic and non-diabetic mothers, with the diabetic mothers, almost the risk of shoulder dystocia is around 50% when the baby is more than 4.5 kilos. And whereas in the non-diabetic mothers also shoulder dystocia occurs, but it is only up to 22%. So it's recommended that if the baby is weighing more than 4.5 kilos, it is better to go for elective cesarean section. And again, can we reduce this risk? So if the mother is diabetic, we can do early induction of labor that would reduce the chances of shoulder dystocia. But if the mother is not diabetic, and if still the baby is macrosomic, can we induce? The answer is it will reduce the shoulder dystocia to some extent, and it reduces the fractures, but it doesn't decrease the brachial plexus injury and also the low Apgar scores and the low COT pH. So how do we manage this shoulder dystocia? What are the warning signs? So after the head is delivered, then you see that the head comes forward with the contraction and retracts back after the contraction. That is called head bobbing sign. And the next feature is the turtle sign, where the face of the baby is tightly applied to the chest after the delivery, and almost the chin is not delivered. That is another sign that indicates that you are about to face the shoulder dystocia. So the things that we shouldn't do when we are anticipating the shoulder dystocia is do not give the fundal pressure, and do not ask the mother to give the push until you disimpact the shoulder, and do not pull the baby from down in wrong direction, and you have to always give the gentle traction along with the fetal spine axis. And if you're not delivering the baby, within 5 minutes from the delivery of the head, baby may have severe HIE. So the common mnemonic which we follow is the helper, and other mnemonic is the pale sister. So the aims of these maneuvers are to increase the functional size of the bony pelvis and also narrow the bisacromial diameter of the fetus and change the position of the bisacromial diameter into other oblique diameter in the pelvis. So the McRoberts position, here we can see that this is the position where most of the time the shoulder dystocia are relieved. We ask the mother to lie flat, and we bring the mother to the edge of the table, and then we ask her to flex and abduct the hips towards the thighs, and someone should gently give the traction from down below. And if this maneuver is not helping, then we go for the next maneuver, that is the suprapubic pressure. And it is same way as how we do the CPR. We have to give the suprapubic pressure from the posterior aspect of the anterior shoulder, and it could be given as a continuous push, or it could be given in the rocking motion. And again, we will have the question, how long each maneuver should be performed? It is for 30 seconds we have to perform each maneuver. And if that is not working, then we have to go on to the next maneuver, that is the internal maneuvers, that is the wood screws and reverse wood screw maneuver. Before we go on to the internal maneuvers, we have to always evaluate our episiotomy. Episiotomy is not to relieve the shoulder dystocia, but it is to give you more space for performing the internal maneuvers. So with the wood screws maneuver, you will put your hand on the posterior aspect of the anterior shoulder, and the other hand on the anterior aspect of the posterior shoulder, and try to rotate it into the other oblique diameter. Suppose if that doesn't happen, then you have to go for the reverse wood screw, where you will bring down the hand that was there and the posterior aspect of the anterior shoulder onto the posterior aspect of the posterior shoulder and try to adduct the shoulder. And this helps to reduce the bisacromial diameter. And if suppose even that doesn't help, then we have to deliver the posterior arm. So you have to introduce your hand from the posterior aspect of the vagina and try to flex the elbow of the posterior arm and try to sweep the hand across the chest and across the face. And if that maneuver doesn't help, then we have to roll over the patient in all fours and then perform the delivery.